Hey everybody, and welcome back to another edition of the Migraine Mentors minicast. We are your hosts, the Migraine Mentors. I'm Dr. Eric Reese, and I'm here with my esteemed colleague, Dr. Thompson Mayasaka. Dr. Mayasaka, how are you doing today there, sir?
I'm doing great, man. Springtime's here, and it's hard not to be in a great mood when it's sunny. How are you doing?
Yeah, I'm really good. I'm really good. It is gorgeous, and especially living in Minnesota when you just have no idea what the weather's going to be like. For those of you who are listening outside of Minnesota, around the world, Minnesota is known for having just horrible winters. So I think we're turning a corner. Third winter may be on its way, but I'm not crossing my fingers and I'm not planning or putting that into the atmosphere. So we'll see what happens with it. So with this warm weather, usually comes more activity, more sunshine, more exciting things to do. And if you're somebody who struggles with migraine attacks, you know that sometimes that can be a blessing, but also a curse. And so there's a lot of discussion, there's a lot of conversation, but Dr. Miyasaka and I really wanted to kind of hammer this home this week about the common misconceptions that are surrounding migraine attacks, migraine triggers, and really like what a migraine really is. So we both have a couple of things we kind of want to challenge everyone's thinking on that we want to dispute and we kind of want to bring some data to the table with. So without further ado, Thompson, what is your first kind of common misconception that you kind of want to speak about today for everybody?
Sure. Yeah, we try not to get super in the weeds here on this one because we can go pretty deep on all these. So the first real common one, sort of a softball for us, is that caffeine is bad or helpful for migraines. I think everyone has a certain opinion on it, and this is kind of a yes and conversation. I know a lot of people when they're in the throes of a migraine will typically, I hear Coca-Cola is one of the common ones that people use. Just a little shot of caffeine helps take the edge off the pain, and that there's validity to that, right? When you're having a migraine, you lose vascular tone in your head, so the vessels get really big and you feel like your head's going to pop off and explode, and you get that like pulsatile sensation. And caffeine naturally is a vasoconstrictor, so it makes your blood vessels more narrow. So in the acute phase, when you're in pain, it can be quite helpful to take off some of the sting, specifically some of the pulsing. The and conversation is larger system at the root of migraine. At least one of the main ones is called the HPA axis. It has lots of really long words. Just look it up if you're interested. It controls a lot of things. Most notably, it controls your stress output. It also controls a lot of the hormones that control estrogen metabolism. So if you are consistently drinking caffeine to the point when you're basically just drinking it so you don't withdraw, you are depleting your HPA axis of the resources it needs to both make cortisol and estrogen. So long term, not the greatest thing. Short term, kind of helpful. So that one's still kind of, it's not really up for debate. Ideally, in a perfect migraine program, you'll cut it out completely and just rely on gentle forms like tea or yerba mate, but we'll get into that at a different time. What about you? What's your first one that you talk with a lot of patients about?
Yeah. I usually will have the discussion with patients, specifically when we're discussing just kind of what a migraine is. I think there's a lot of patients that come in with preconceived notions where they are like, well, I have migraine symptoms every day. And I'm like, oh my God, that's horrible. And I tell them, I'm like, well, listen, do you get headaches? Like tension headaches, and do you also get migraine attacks? And they're like, oh yeah. And I was like, okay, well then good. Like we can kind of start splitting hairs a bit. And so, one of the things that I think I have a conversation with a lot of my patients about is just the differences between what a migraine is and what a migraine isn't. And so my kind of common myth that I'm kind of dispelling is that, everyone who's outside of the migraine community is like, oh, I had a really bad headache. Oh, it's a migraine. And I go, well, hold the phone really quick here, because migraine attacks are actually a little bit more similar neurologically to seizures than a tension headache, right? And I think that on the outside, that sounds really scary, and it's kind of a bit of a whirlwind. But what I mean by that is the neurological cascade, the inflammatory response, the changes in the brain that occur are closer to a seizure event than how like a tension headache would represent, right? So they both present very differently. They're both triggered very differently. They have different patient presentations and histories, and so I usually start off with that to make sure people know kind of what they're talking about, because I find most doctors don't really educate patients on the type of headache or migraine or symptoms that they're having. So that's kind of my first one where I'm really like, listen, you can have headaches and you can have migraine attacks. They're not mutually exclusive, but they are separate entities and separate conditions. So That's usually the one I usually start off with. What's your other common myth that you have conversations with patients about?
Yeah, a point you made really brings up a debate that's been happening for at least 200 years. It's been happening since the beginning of when people started to discover what migraines are, and it's migraines are purely vascular. So if you look at the research and the therapeutics that are coming out, CGRP medications, triptans, a lot of those are specifically designed to act on the vascular, the blood vessels in your head. And so the tennis match that's been happening in the scientific community is it vascular or is it neurological? Is it a problem with the actual vessel itself, or is it a problem with the software that controls what the blood vessels do? And you can, trace it back. There's these things called sphenopalatine ganglion blocks, SPG blocks, that basically take the software that sends the signals to the vessels and shuts it off. So when you consider that, there's this little bundle of nerves that controls the input to the vascular system. You can start to ask the question, and the scientific community has been debating it for decades now, is it the neurological systems that tell the vessels what to do, which is the primary model that we practice through, or are you better off just aiming at the vasculature itself? And that's most of the medications that you're all taking are specifically in the vascular model. So we don't get into that super often with patients. I think it's more just the general understanding about what migraine is completely centered around that concept: is blood vessel problem or neurologic problem. And I think it's usually a little bit of both with everybody. We practice almost exclusively the neurologic model, and we have amazing success with people with migraines. So there's at least some validity to both. But I think just the collective understanding has always been a tennis match back and forth between those two models, which I always thought was really interesting. I had no idea about that until I started reading about it.
Yeah, that's a really good one. I think that there's still so much of a debate going on. And even in the literature, when we look at it, there's still like this tandem, dualistic kind of two camps, and I think we kind of find ourselves in the center, maybe leaning more towards the neuro just because of how we practice, but that's fair. One of the other ones that I think is quite interesting that we talked about was the fact that there's a lot of consideration, we'll say, going on about migraine triggers, right? So when you're thinking about what actually happens with a migraine, and people are like, okay, it's histamine, degranulation, it's the dark chocolates, it's the red wines, it's all these things that trigger. Well, Thompson, you brought this up before we were discussing it, and I'm going to take it from you and throw it to the team. Is there's research showing that migraine symptoms are preceded by like 24 to 48 hours by neurological changes. And so it's the question of, is this process going on, and then you become sensitive to the actual triggers that we think trigger a migraine? Or are these triggers actually causing the inflammatory cascade that we thought? Well, there's some debate now about whether or not, those things actually do cause the actual migraine to occur, or if they're just part of this ramp up process that's already been taking place for 24 to 48 hours. And so that's an interesting conversation as well. I think there's more research, more data to show it. I think I've seen patient cases where they would say, hey, listen, every time I have red wine, it's always a trigger no matter what. And they would kind of maybe go to bat on maybe being in one camp versus the other. But I think that that's another interesting kind of common myth that we still don't actually fully know all the data and information about.
Yeah, that one's really interesting. It's if you talk to anyone with ongoing migraines, before there's pain, a lot of overwhelming majority will just have this hard to explain intuitive sense that something is happening. They just know hours, sometimes a full day before it really hits the fan of like, "Ugh, this sucks. I know this feeling." And those are the times, like right when that sort of hard to describe feeling comes on, that like bright lights or super loud noisy environments or eating the wrong thing, like that could be evidence that the migraine's already happening and the whole brain is just hypersensitized to all of those stimuli ahead of time. Interesting. It's very interesting to look at triggers that way, to think that it may just be a migraine that's already started.
Yeah. Are there any other ones that you have found doing your research where you're like, oh, this is interesting, and this is something that I've talked to patients about in the past?
I think another really interesting one is centered around auras. I know a lot of people, I've had even migraine patients say, well, I don't get an aura, so it can't be a migraine. And there's diagnostic criteria for both. There's migraine with aura and migraine without aura. And we've spoken on it a bunch of times here. Is you look at the things when a migraine starts, like when you really like the storm is here and you know everything is about to just totally hit the fan. The areas of your system that are the most unstable are the ones that are going to give you symptoms. That is how migraines largely are diagnosed. So if the instability happens in your vestibular system, that area gets knocked out by the electrical storm and then you get dizzy. The occipital cortex, which is right here in the back, it processes all your vision. If for some reason that's unstable as the migraine proceeds, you will get visual symptoms that are collectively known as aura symptoms. I get them. I get these things called ocular migraines about twice a year. I'll get this little spot in the middle of my eye and it'll grow into like this moon shape and eventually disappear after about a half an hour. And then nothing really happens. I get kind of gross and nauseous. I feel a little hungover, but ultimately I can carry on. So you don't have to have visual symptoms or an aura. It's actually kind of a blessing too. Honestly, I always thought that was kind of nature's way of throwing you a bone because there's actually, if you look up migraine diagnostic criteria, there's separate diagnostic criteria for aura and without aura. I thought that was interesting. Last month, I had a patient say explicitly to me that I don't think I get migraines because I don't get the little visual spots. And that was like, I guess that's something that most people think is a requirement because a lot of people do have it, but it's actually pretty common to not have it as well.
Yeah, that's a really good one. I think, before we got really heavy into the migraine space, I think to be fair, would have probably been in one of those camps, be like, no aura, no migraine. You're dealing with a really bad headache. But now that we know so much more and the data has just been so clear, like it's just tough to go back on that once you learn it. It's tough to, go back to how you used to think when you know so much more now. So yeah, that was great. I think that was a ton of information, a ton of really good content, and more importantly too, hopefully educational for so many people out there. With that being said, Thompson, anything that you want to leave our viewers with today for kind of a last hurrah or last message?
I think just a reminder, do the basics. Do the basics. Take care of your stress, manage your histamine, take your electrolytes. I think that's a really good foundation to start from. We'll harp on all of those things from the very beginning, but low glycemic food, low histamine, high electrolytes, that will get you so much farther than any fancy combination of therapies. I think if you just master the basics, it'll take you further than you ever thought possible. What about you? What's your send away?
Stick to the basics. There's no way to get away from it. And as much as people want to take supplements and they want to do special diets and they're like, I want a new vagal nerve stimulator. I'm like, yes, and you're not going to get anywhere without sticking to the basics. Your diet, your exercise, your nutrition, your sleep, your stress management, everything you said, and then some has to be on point. And if you're not doing any of that, then you will continue to spin your tires, keep looking for solutions, and pay way too much money for getting way too little outcomes. And so if you're stuck in that mode, if you don't know where to turn, if you don't know what to do, reach out to us. Okay. Like we are always fielding calls. We're always doing consultations with people. We're always trying to help people. If we think we can help you, we'll be honest. And we don't think we can, we'll help help you find care somewhere else, or we'll figure out what a solution looks like for you. So the best thing you could do is reach out and just have a free consultation and free call with us. So with that said, if you are a subscriber to our newsletter, thank you for supporting us. We can't thank you enough for that. If you aren't a subscriber for the newsletter yet, what are you waiting for? We're giving you free content, free education, more information like this every single week, actionable insights, tips, tricks, education, everything that you can do to help manage your own migraine attacks and symptoms in the comfort of your note. And we're trying to do it with little to no influence with medications, pharmaceuticals, just taking an integrative approach. We're not anti-medication, we're just pro-integration. And so we want to thank you for joining us today. If you've got any questions, feel free to reach out to us. If you're not a subscriber, click that subscribe link in the description below in the YouTube video. And we look forward to hearing from you and seeing you at next week's presentation, newsletter, and podcast.